Hi, everybody. I am Dr. Shaila Sheikh from Mumbai Sefi Hospital, again back with you today on the 20th episode of the 4D program, which we all know goes live every Friday at 9 p.m. And today we are going to discuss something which is very important, very pertinent, and a topic which is of great interest to all of us because we are going to be discussing about the burden of type 2 diabetes in India. What are the challenges and what are the solutions? And to discuss this, we have none other than Dr. Arpit Garg, who is a consultant endocrinologist from a very, very special place. He's from Amar Super Speciality Hospital, Patiala, a great endocrinologist, and more than that, a great, I would say, a person with number of publications, loves doing research, great work experience of almost a decade, and a member of not only the Endocrine Society of India but also member of the Endocrine Society USA. So warm welcome to you, Arpit. I'm sure this is going to be a very, very interesting session, and we're going to hear some great bites from you as to what is it that makes India the diabetes capital of the world. I hope that someday we can say the diabetes care capital of the world.
Thank you, ma'am. Thanks for the nice introduction. Yeah, it's a very relevant topic nowadays because we are seeing continuously increasing prevalence of diabetes in India, and it is definitely going to become a diabetes capital. And we also hope that one day India will become not only the diabetes capital, rather the diabetes care capital of the world. Today, I'm going to discuss about burden of diabetes in India, challenges and solutions. Yeah, can you add my slides on the screen? So this is very important thing. Burden of diabetes. As we all know that diabetes is a very morbid disease. It doesn't come alone. It comes along with the various complications which are called as the micro and the macrovascular complications, which make the management of diabetes even more difficult. And it carries a huge burden on our healthcare cost also. If we see the morbidity and mortality in our patients in the hospital studies, approximately 40 to 50% of the patients they are having diabetes or some complications of diabetes. So if we are able to diagnose these patients early, if we are able to treat them properly and prevent the complications, then I think we can mitigate the burden of this deadly disease to a great extent. So I am going to discuss about the various challenges which we face in the management of diabetes and the various viable solutions which are there with us. If we see the statistical data, do you know that in India, every 1 in 11 adults is living with diabetes? Over 53% of adults living with diabetes are undiagnosed. This is a very striking thing that more than half of the patients who are actually having diabetes, they are not diagnosed with diabetes. If they are not diagnosed, then how can they be treated? Over 50% of the adults living with diabetes are still undiagnosed. Number of people with diabetes in India is the second highest in the world, and 40 million adults in India they have impaired glucose tolerance, which places them at higher risk of developing type 2 diabetes. The rise in the number of people with type 2 diabetes is driven by a complex interplay of socioeconomic, demographic, environmental, and genetic factors. And approximately 747,000 deaths are directly caused by diabetes, and this is the data from 2021, which is a huge number. That is 747,000 deaths they were attributed to diabetes. If we see the prevalence of diabetes in India, the prevalence has been increasing continuously since in the last decade. If we see data from 2009 to 2019, there has been gradual increase in the prevalence of diabetes. This may be due to the increasing like healthcare awareness, which leads to more number of patients who are being diagnosed with diabetes. Secondly, it is due to various other factors like our changing lifestyle, due to which more and more people are actually suffering from diabetes nowadays. And if we see the state-wise data, the prevalence of diabetes is very high in states which are having good socioeconomic backgrounds like Punjab, Chandigarh, where the prevalence is around like 10%, more than 10%. And in Maharashtra, it is 8.4%. So these are few states where the prevalence of diabetes is quite much as compared to the states like uh, Bihar, where it is 4.3%, Jharkhand, it's 5.3%, and Arunachal Pradesh, it is 5.1. So the states which are little less developed, they are having lesser prevalence of diabetes as compared to high developed states. So, what are the challenges we face in the management of diabetes in India? One is the reduction in the physical activity, increased availability of processed foods, aging population, overweight and obesity, and perception of diabetes. We all know that as we are moving towards a developed society, more and more people are affording vehicles like scooters and cars, and they are walking less or on foot, and they are using more of the vehicles now to even to travel for a short distance. And there is increased availability of processed foods without variation in the society. Even the people from the lower socioeconomic strata also, they are having access freely free access to processed foods because these are available at every nook and corner of the society now. Aging population, as we are having good healthcare system nowadays, the life expectancy has increased, and that's why aging population, that is population more than 65 years of age, has been continuously increasing in India also. Prevalence of overweight and obesity has been continuously increasing due to the same reasons, that is bad lifestyle, less physical activity, higher intake of calorie intense foods, and perception of diabetes. Some people feel that diabetes is a blot. They do not disclose diabetes. They do not want treatment for diabetes. Some people feel that blood glucose levels do not harm that much as compared to the tablets of the diabetes, as compared to the medications which are used for the management of diabetes. So these are various myths which are associated with diabetes, and due to these reasons, the diabetes management is very challenging, especially in the Indian scenario. If we see the rural versus urban divide, a report was released in Lancet in 2017. Lancet is a very landmark journal, very prominent journal in the field of medicine, and it showed that the prevalence of diabetes was almost double in urban areas as compared to the rural areas. And it further highlighted that in urban areas, the prevalence of diabetes was higher in individuals of lower socioeconomic status. And this was attributed to increasing availability of fast, relatively cheap foods in recent years, which means poor diets are easily found across all income brackets. The same thing which I have told in the previous slide, that cheap foods, calorie intense foods, these are easily available across all the income brackets. It is not like about 30 years back when fast foods, they were only available to good good financial strata people. It is nowadays these are very easily accessible at all the shops, and even the fast foods which are cheap, they are calorie intense. So, distribution of direct cost in diabetes care. If you see here, the distribution of cost, highest cost is related to the hospitalizations and doctor visits and anti-diabetic drugs, and lesser to the monitoring and the lab test and disposable. So, if we treat the diabetes properly and prevent the long-term complications of diabetes, then we can definitely reduce the hospitalization costs in the long term, and this will definitely mitigate the financial burden on our patients. So, what are the various possible solutions for these challenges which we are facing in our population? One is, which is I think first of most important, is the improved education to alert the population about the risk factors for diabetes. If patients are aware about the various uh, complications of diabetes and what are the various symptoms of diabetes, then I think they will be more understandable. They will more acceptable to the diagnosis of diabetes, and the compliance to medications will increase. Training of patients to manage their disease more effectively. If the patients are self trained how about monitoring of their blood glucose levels and adjustment of the insulin doses, then definitely they can treat their disease in a more effective way, and they can keep their blood glucose levels in within a normal range. Development of more structured care delivery. Obviously, if we have a very structured healthcare systems where a patient comes and meets first a primary care physician, then a super specialist, then he goes to a diabetes educator, proper lab tests are done, then the diabetes care can be improved to a great extent. In India, we are have a paucity of educators, clinicians. All clinicians do not have the facility of educators in their OPD, and that's why patients are not properly educated regarding the risk factors for diabetes, regarding the various treatment options and monitoring of blood glucose levels. Because the patients are not well educated about these things, then obviously the compliance to drugs will definitely decrease in the long term. Management of cardiometabolic risk factors, it is one of the very important thing, because we know that In the long term, the major cause of morbidity and mortality in all the diabetic patients is cardiometabolic disease or the cardiovascular disease at some level. So, if we are diagnosing this cardiovascular disease early and if we are properly treating this disease, then we can definitely decrease the morbidity in the long term. So, it is essential to diagnose the disease early and start aggressive management of glycemia and associated cardiovascular risk factors. The most important thing is when we are talking to our patient is to identify the barrier. What is the barrier in the patient's mind? What is barrier in our mind? And we have to address all these barriers, and only then we can improve the outcomes. So there are first patient related barriers like lack of awareness, economic stress, denying the risk, stress, changing behaviors, and sustaining the changes which are difficult. Second comes the rural barriers like high rates of illiteracy, poverty, different socioeconomic strata, multilingual population, cultural, religious customs, superstition, and beliefs. And barriers related to medical profession include medical training focused on acute care. Even nurses find acute illness treatment more rewarding and better paying. Cost of having a team of for diabetes management and lack of trained paramedics. So these are the barriers which are at the level of the hospitals. If we address all these barriers, and only then we can improve outcomes in type 2 diabetes. Strategies to manage the pre-diabetes. So pre-diabetes is the earlier stage of diabetes, and the main strategy to manage pre-diabetes is the optimal lifestyle management. The first step in managing patients with pre-diabetes is to encourage strict lifestyle modification, which consists of more than 180 minutes of physical activity per minute per week and calorie intake of 1200 to 1800 kilocalories per day. In addition to lifestyle management, anti-obesity drugs like orlistat, lorcaserin, and phentermine topiramate they can be considered in patients with obesity. Healthcare providers can also consider pharmacologic agents like metformin, pioglitazone, liraglutide for management of prediabetes. If medical management fails to achieve glycemic control, then advanced measures such as bariatric surgery can be used with the goal of reversing prediabetes and helping obese patients lose weight. So these are the various steps which we can which we should try whenever we are managing pre-diabetes in our patients. So coming to the treatment strategies for diabetic patients, first and foremost is the lifestyle modification, and after that comes the pharmacotherapy or the use of medications. Usually in our OPDs, what I have seen is that even the medical professionals they give less time to the lifestyle modification part. They directly jump to the medications, and they just tell the patient to reduce their calorie intake and do exercise. But this is not enough. We have to tell the patient about the accurate calories which he should take. We should make a meal plan for the patient. If you are not having adequate time as a clinician, then you can employ diabetes educators who can spend time with the patient and formulate a meal plan for the patient and formulate a exercise plan for the patient. If the blood glucose levels are still high despite of adequate lifestyle modification, then definitely we have to move on to the drugs. And the various drugs which are used for the management of diabetes are like metformin, which come in biguanides, and then we have DPP4 inhibitors like sitagliptin, sexagliptin, SGLT2 inhibitors like canagliflozin, dapagliflozin, empagliflozin, and GLP-1 RAs like liraglutide, dulaglutide. So there is a plethora of drugs which is now with us for the management of diabetes. And the one of the novel combination which we are having for the management of type 2 diabetes is a combination of SGLT2 inhibitor and DPP4 inhibitor. I'm not going into the detail of pathophysiology of diabetes, but there is thing called as omnious octet for the type 2 diabetes. And if we see the mechanism of action of these two drugs, when these are combined together, we are able to target almost all the components of omnious octet. And that's why this combination particularly attacks the basic pathophysiology of type 2 diabetes. Like SGLT2 inhibitors, these cause glucosuria. They have indirect pancreatic effects by increasing the beta cell sensitivity, decreasing the glucagon levels, and dual pancreatic effects like with increasing insulin secretion, and effects on intestine, leading to increased GLP-1 and increasing GIP. So all these effects they lead to decrease in the blood glucose levels, along with pleiotropic benefits of weight loss, nephroprotection, cardioprotection. So a lot of benefits are there with SGLT2 inhibitors and also DPP4 inhibitors. That's why the combination of these two drugs is very promising in the management of type 2 diabetes. So this combination is a suitable option for type 2 diabetic patients because of these reasons, like safe, rapid, and sustained glycemic control, improvement in both insulin resistance and beta cell function, helps reduce the body weight and blood pressure, reduces pill burden, and overall cost effectiveness. Other strategies like dietary intervention is vital management. We should encourage the patients to take low glycemic index foods like whole wheat, brown rice, oats in every meal. Avoid refined carbohydrates, avoid refined cereals like white bread, noodles, white rice, etc. Exercise is most overlooked self care but should be considered in relation to the drug regimen. And it is important to get the A1C test done either twice a year or once in 3 months. And if it is within the targets, it's okay. If it is still high, then you should definitely contact your healthcare provider and take proper pharmacotherapy.
Totally agree with you, Arpit. I'm totally on the same page as far as that is concerned. But Arpit, what do you think is the current status? I mean, when you talk about primary prevention, we talk about preventing diabetes, we're talking about preventing pre-diabetes, or we're talking about preventing progression of pre-diabetes to diabetes. Globally, if I take it in India, what do you think? Are we really there, or are we lacking something?
It's a very relevant question, ma'am. That if what are we doing in for the prevention of diabetes or the conversion from pre-diabetes to diabetes? Because it is the first step in the management of diabetes. That is, you have to prevent the onset of diabetes per se. And I must say that we are lacking in this part because if you see the clinical scenario in India, especially in India, people are more focused on taking the medicines and just writing the medication and advising the patient, but we are not emphasizing on the lifestyle modification, which we should. And in every book, in every guideline, maybe it's national, maybe it's international, everywhere it's written that lifestyle modification is the first part of management of pre-diabetes or diabetes, and this is the only thing which can prevent conversion from pre-diabetes to diabetes. So I think we should focus more on this part, that is lifestyle modification. Either we can do it ourselves, or keep we can take help of our diabetes educators who can tell the patients about various measures to be taken. The basic thing is that patients have to be educated about this thing, and only if the patients are educated, only then we can reduce the burden of this disease.
I totally agree with you, Arpit. I think an educated patient is an empowered patient. And we really
Yes.
need to go that extra mile to be able to emphasize on lifestyle. We just don't do enough as far as lifestyle is concerned. Do you think we don't believe that much in lifestyle, Arpit? That's why we just don't emphasize as much as we should? Or do you believe that it is inadequate time that does not allow us to emphasize so much about lifestyle?
Yeah. So in this case, ma'am, I must say that we believe in that lifestyle modification is very important. But the problem in India is that due to a higher number of patients, we do not have adequate time, or we are having paucity of time, because
Totally.
education needs time. We need
Yes.
at least 15, 20, at least 30 minutes to educate the patient. But if you see,
Agree.
doctors are seeing like 50 patients, 100 patients in their OPD, and it is practically impossible for any clinician to educate the patient for 30 minutes if he is seeing a busy OPD. So
Very
this job is done by diabetes educators, and there is a paucity of diabetes educators in India. These are there in big corporates are there. Some doctors are keeping them, but at the primary level, at the secondary levels, diabetes educator facility is still not there. And at that level, 90% of the patients are being treated at the primary and the secondary care. Very few patients reach the tertiary care clinics. So it is very important to uh, keep a facility of diabetes educators at least at secondary care. Only then we can educate our patients.
I agree with you. I totally agree with you, Arpit, and I think that's a very relevant point you've just made. And Arpit, do you think it could be the, I mean, our degree of knowledge or lack of awareness? I mean, that we really don't worry so much about diabetes right at diagnosis. Is there some kind of difference in knowledge as far as our urban and rural areas go, as far as diabetes is concerned in our country?
Yes, ma'am. It is a very important thing that people, if you see the population in India or the people in India, they are aware about the diabetes, but they feel that when diabetes is diagnosed, they feel that it is not important to take the medications, because they feel that if you start medicine, then it has to be taken lifelong. So they want to delay the treatment. They want that initially there is no need to take the medicine after 5 6 years. When you feel something, when you feel some problem in your body, only then you should start medicine. So even some of the clinicians, even the clinicians are not aware that initial early treatment is very important for the management of diabetes. They are not aware about the legacy phenomena. So we need to make the clinicians aware about this legacy effect, and only then we can make the patients or our population aware about these things, that the treatment of diabetes is very important from the very beginning. See, if the patient is feeling any symptoms of diabetes, this means he is having complications of diabetes to some extent. So patients start feeling numbness in the feet or burning in the feet, and then they come to the doctor to write a medicine for diabetes. This is wrong, because at that time patient is having already having established neuropathy, and once a complication of diabetes develops, it doesn't revert usually. We can only halt the progression of the complication, but we can not usually reverse it completely. So it is very important to treat diabetes from a very initial stage, so that we can prevent the emergence of these complications.
I totally agree with you, Arpit. I think, as you rightly said, we miss the concept of metabolic memory, and as you said, not only complications of diabetes, but if you really really are sort of more careful right at diagnosis, it also makes a very big difference to our macrovascular complications, and also it makes a very big difference to mortality. So I think that is a very, very important message that you're giving, that you need to be careful right at the beginning. When you talk about medicines, Arpit, when we talk about medications, do you think that the Indian market favors medications in any way, OHs versus insulin? Do you think expense matters since our patients are paying from their pocket? Do you think there's any variability as far as medications and insulin goes, as far as our Indian subcontinent is concerned?
Yes, ma'am. In India, definitely medications are definitely overprescribed. So, if a patient is still having OHA failure, that is over oral hypoglycemic agent failure, if the patient is having, I've seen patients taking more drugs on the top of that, and still their blood glucose levels are not achieved. So, this is mainly because of the, you can call it as the clinical inertia, or there is some reluctance in the patient minds also, because they feel that once they are on insulin, they will have to take the injection lifelong. Secondly, patients are not aware that insulin has come in various forms, like pens are there, pumps are there. They still feel that they have to take a injection with a syringe, conventional syringe, and they have a phobia for this in their mind. Secondly, finances definitely play a role in India, because we have to buy medication from our pocket. The insurance system is very limited in India, and that is limited to the inpatient only, and we do not have insurance for the outpatients. So patients have to buy insulins from their pocket. Though insulin is not that expensive as compared to the Western world, but still it is the cost increases after the initiation of insulin, because once a patient is on insulin, then he has to definitely monitor his blood glucose levels more frequently. So the cost of the glucometers and glucose strips also adds on. So these things definitely add to the reluctance to the use of insulin in the patient's mind as well as on the clinician's mind. Thirdly, what I feel is that whenever a patient is prescribed insulin by a doctor, the patients, most of the patients, they stop coming back to their doctor. They try to contact some other person, especially in the rural areas or in the lesser developed areas where the patients are not that educated. So because of the fear of this thing, clinicians are sometimes reluctant in writing insulin. They just keep on adding one drug on the top of the other because they don't want to lose the patient. So I think these barriers have to be addressed in the clinician's mind, in the patient's mind. Only then we can rationalize the diabetes management in India.
I agree with you, Arpit. I think there's a lot of patient inertia, a lot of clinician inertia as far as initiating insulin. Sometimes initiating drugs is also concerned. Because, as you rightly said, a number of patients believe that they can manage with lifestyle. But the only issue is, though they may adopt at least initially a good lifestyle, subsequently they don't monitor whether the lifestyle is really working or not working in them. So I think a very important message which you are giving across the board is, okay, please monitor. Depending upon what is working best for you is what we could then potentially take it from there. But you need to treat to target, because if you don't treat to target, whichever targets you decide individually for your patients, we're just not going to be at goal as far as your patients are concerned. Arpit, the most important question that a patient sits across and asks you in the consulting, after, as you said, even after maybe seeing another 10, clinicians, is, Doctor Saab, mein kya khaun? That is, I think, the most favorite question of every patient who comes to you. And do you think that as a cuisine, as you know, we are a multicultural country, so much of cuisine in our country, different varieties, different regions. Do you think our Indian cuisine is really, adapted to diabetes, or do you think that, our patients really have a tough time when they're diagnosed with diabetes.
So it's a very interesting, and rather I can say it's a most important question of the discussion that patients often ask, Doctor, मैं क्या खाऊं? Because it is the biggest thing in the patient's mind also. Because as an Indian, I also and most of the Indian population, the one thing which continuously roams in their mind is the food. So they are obviously worried what they can eat, what they can't. And the general perception is that whenever you are diagnosed with diabetes, you have to stop eating a lot of things. You can't eat sweets at all, and you have to take boiled vegetables. So this perception is there in the patient mind. So whenever patient asks me this question, I always tell the patient there is nothing that you need to stop completely. Only very few things like direct sugars, certain fruits like grapes, which you have to totally avoid. Rest of the things you can take, but in moderation. Once your blood glucose levels are well under control, you can take everything, but in moderation. It is not like that you can't take sweets. You can even take the sweets, you can take, but it's not like you have to take the bowl or whole katori you should consume. You can just taste it. You can take 1 or 2 spoons of that if your blood glucose levels are controlled. But as far as the Indian diet is concerned, so there is a deficiency in Indian diet, that it is a carbohydrate rich diet. So we all say that we should follow balanced diet, but practically balanced, it is very difficult in India to follow a balanced diet, because in balanced diet there is 50% carbohydrates, 30% of the calories from the proteins, and 10 to 15% fats, and about 25 grams of fiber per day. But in India, if you see any like North Indian or South Indian food, approximately 60 to 70% calories are coming from the carbohydrates, and about 10 to 15% is the fat, and 5%, less than 5%, is the protein. So if even if you ask the patients to increase their protein intake, it is very difficult to 30 to 35%. And even in patients who are non-vegetarian, it is very difficult because even those who are non-vegetarian, like I can tell about the North India patients who are non-vegetarians also, they take non-veg once or twice a week, not more than that. And in patients who are vegetarian, I think it is impossible to achieve this protein intake of 35% of our total calories. So this is a deficiency in the Indian diet, that people take less proteins and more carbs. Indian diet is a carbohydrate rich diet, because chapatis and rice are the staple in our food. These are the main crux of our any diet. So we have to tell the patient that you have to reduce the cereals in your diet, you have to reduce the chapatis or rice, and increase the amount of fiber, increase the amount of proteins, and fats have to be kept in moderation. So so that's why we started from the very beginning. We told you, we discussed about this thing, that dietary counseling is very important, and it is even more important in India, because Indian diet is not that great as far as diabetes is concerned.
I honestly like your advice, Arpit. It is so reassuring to hear that, okay, you can have everything in moderation. Be careful, but it is not that, except for, of course, some of the things which you just mentioned. Your patient is a little reassured when they're told that life is not going to be all black, it can still be colorful. Otherwise, a
Suddenly,
lot of
smile appears on the patient's face. Suddenly, smile appears on the patient's face when I tell this line. Suddenly, patients say, "It's okay, doctor. Now we are ready to like take the medicine. We'll face the disease." But before saying this, patient are obviously like down, and they are saying, "What has happened to us?" They are in depression, and the family is in depression, that he can't take anything now. He can't take. Wives are scolding their husbands that you have to stop this thing. You have to stop that thing. So always say there is nothing to stop. You can take everything, but just in moderation.
the wife got a one more reason to
Yeah, yeah.
to tell the husbands what to do and what not to
Yeah,
do.
yeah. So that is the most important thing in Punjab.
Arpit, one last question to you. So, I mean, if you're really in a nutshell, if I ask you in a nutshell, if I had to you to have to give me 5 bullet points as to, what would your recommendations be to a diabetic patients? I mean, if you think that this is, ma'am, the most important 5 things which I want my patients to remember, what would those 5 points be? And then we can call it a day.
Yeah. So, in nutshell, I would say that first and foremost is follow proper diet. Either take dietary advice from your clinician or from a diabetes educator or from, say, any certified dietitian you can take. Secondly, follow proper exercise plan. Thirdly, monitor your blood glucose levels. And if your blood glucose levels are high, don't hesitate to take medicine, because if once complications of diabetes develops, then it can't be reversed. So if you require medicine, start it from the very beginning. And once you are prescribed medicines, just keep monitoring your blood glucose levels. It is very important to monitor your HbA1c, that is glycosylated hemoglobin, which is 3 months average blood glucose levels. And though the targets have to be individualized, but more or less we say that it should be less than 7%. And lastly, you have to be aware of the complications of diabetes, like cardiac complications, neurological complications, renal complications, and talk to your doctor whenever you visit him. For the anyways, doctors screen for these complications, but if by any chance you are skipping, then you have to do the investigations for screening of these complications. And if you feel that you are developing any complications, like you are feeling some sensation, abnormal sensations in your feet, or burning in your feet, or numbness in your feet, you should immediately contact your clinician and take appropriate measures for that.
I think in a nutshell, Arpit has put it across very well, that what you need to do, when you need to do it, how you need to do it, so that everybody can practically have a complication free life, even if they are actually suffering from diabetes. Moderation is the key word. Medication, very, very important. Monitoring for complications, equally important, so that we can preempt them rather than treat them. And that was absolutely fantastic, Arpit. It was a great learning from you. And I'm so glad that we could connect today. And a big thank you to all the listeners who have logged in to be with us today till the next episode of 4D. Thank you.